You are welcome to my channel. Thanks for visiting. If you haven't subscribed, please kindly do. But if you are subscribed and you are visiting again, I'm saying a big thank you. Without wasting your time, let's go straight again to infective endocarditis, focusing on how to make the definitive diagnosis through microbiology. The hallmark of infective endocarditis is the presence of inflammatory changes in valvular tissue at the site of vegetation attachment. Also, fever will continue as long as there is bacteremia. Generally, it is important, actually compulsory, to know the culprit, and the diagnosis can take us through three different areas. Clinically, we can take history, clinical features, signs and symptoms, physical examination, particularly peripheral stigmata of infective endocarditis through the hand. You can see the heart through the hand, right? And of course, the risk factors. We should know all these. Then we'll head to lab. That is where we are right now. Microbiology, then later on, cardiac enzymes to rule out myocardial infarction. We've gone to radiological investigation, echo, CT, and the rest. Check my channel for that. So back to the point. Today is all about laboratory diagnosis using microbiology. The initial considerations. When can we obtain sample? When we are likely going to embark on empirical treatment or definitive treatment. The first factor is whether the patient is stable or unstable. Stable patient, yeah, you can take the sample before giving any antibiotics or before starting any empirical treatment. But the unstable patient, if you can do it quickly enough to obtain the sample, but don't, because you want to obtain the sample, then keep the antibiotics away. No. But even if your center is not so equipped with so many hands to help, within 48 to 72 hours of the onset of empirical antibiotics, you can obtain the sample. Then, you can repeat MCS after if there is need for that. And of course, you will do as you continue with definitive treatment. Now, let's get to the business proper. Microbiology study here will be through blood culture. 3 sets of blood culture will be needed. A set will be of 2 bottles, one for aerobic and the other for anaerobic microorganisms. How to take the sample and the time apart. Take the sample before giving antibiotics if the patient is stable. Even in an unstable condition, if you have many hands, one person can be taking the sample while the other one can be administering the intravenous antibiotics empirically. 10 ml of blood is needed in each bottle. Each sample should be taken from a separate vein site. No regard to temperature or time of the day. You can take it at any time. Well, the best is take it immediately you are able to once the patient is with you. Take each sample at least 12 hours apart. You know, we are going for 3 sets, right? Most agents will be dictated now at 48 hours, but HACEK group is fastidious, so may be dictated within 5 to 7 days. If prior antibiotics has been given, we will need more cells. So we will need additional 2 to 3 cells over 5 days. Can we go through the list of possible microorganisms? Yeah, but I won't do that here right now. There is a separate full presentation on that already published. Here is the link. Actually, some authors will, from the beginning, call infective endocarditis bacteria endocarditis. Why would they give the name bacteria endocarditis? Because 80 to 90% of the times, infective endocarditis will be caused by bacteria. So you can get the details here of all microorganisms that could cause infective endocarditis. But let me quickly brush through some common bacteria that will be involved. Staphylococcus aureus, Streptococcus viridans, or Staphylococcus galolyticus, that is formerly known as S. bovis. HACEK group, or commonly acquired enterococci, could all be involved, in addition to fungi, and the list goes on. Just go through this thing, you understand better. If somebody will ask me, can we have false positive? The answer is yes. We can have false positive with Cotibacterium, formerly known as Propionibacterium acne. We can have false positive with Bacillus species, also with coagulase negative Staphylococcus, and also with Corynebacterium species. What if the culture is negative? And we'll be dealing with culture negative infective endocarditis. Yes, that is pretty true. We can have culture negative infective endocarditis if after 5 days of incubation, all the 3 cells have been returned and all negative. Then we should think about some issues here. Number 1, has antibiotics been given and that has prevented the growth of the agents? Or we are dealing with fastidious agent with fastidious characteristics that will demand more to grow, right? Or we have intracellular bacteria that cannot be cultured with the standard methods. But something will remain, even in the face of all these probabilities. The fever will be persistent. The echo would have confirmed the presence of vegetation, probably the presence of abscess, intracardiac abscess. In some, they would have likely come down with complications like stroke, and physical examination would have proven that the peripheral stigmata of infective endocarditis is right here. You'll be able to see the heart through the hand, right? And of course, cardiovascular examination would have established a new heart murmur, and some will already be done without failure. Then, what else are we going to do? Let's go. If we have culture negative infective endocarditis, what other laboratory investigations can we have done? Yes, we can have serology, we can have polymerase chain reaction done. Okay, I agree. It is infective endocarditis and it is culture negative. What are the possible culprits here? Yeah, could be chlamydia, legionella, mycoplasma, brucella, bartonella, or Coxsackia bonentis species. They could be responsible for culture negative infective endocarditis. Another question is, what other investigations can we embark upon if we are faced with culture negative infective endocarditis? We can have histology done, histology of the vegetation that is seen on echo, or that of intracardiac abscess. And of course, we can have resected valve. Now, under a very strong suggestion of infective endocarditis, we can have resected valve cultured. Finally, I will conclude the way I started because it's pretty important. We should know the time to obtain the sample in relation to empirical and definitive treatment. If the patient is stable, we can buy time. We can take the sample, then we'll be doing other stuff like taking, for echo and giving empirical treatment as the case might be. But we don't have the luxury of time in an unstable patient. So if we have more hands, while one person is preparing the intravenous antibiotics, the other should be taking the sample for microbiology study. However, if we are forced to a corner, we don't have enough hands to do that at the same time, then within 48 to 72 hours of the onset of empirical intravenous antibiotics, we are fine to still take our sample, and we'll repeat the sample as we continue in the treatment. When the lab result is back, we'll then review with the lab result and embark on definitive treatment. But we must never make that mistake of holding the empirical intravenous antibiotics simply because we would like to have the sample taken. Thanks for listening. Remember to share this with your friends on your platform. Remember to subscribe to my channel. I appreciate it.